and not tired or hurting or anything like that. And I'm switching to flip-flops, so I can't walk anymore in those shoes. Our first speaker this morning is Dr. Kelly Goldsmith. She's a professor of pediatrics at Emory University School of Medicine and an attending physician at Aflac Cancer and Blood Disorders Center. She is also the director of the Neuroblastoma MIBG program and clinical director of the Aflac Precision Medicine program. She received her bachelor's degree at Duke University, her doctorate at the University of Alabama, Birmingham, and did her residency and fellowship and postdoctoral research at Children's Hospital, Philadelphia. She is the author and co-author of, again, many publications, sits on many boards, including the COG and the NANT. She was also the co-chair of the study on the use of lorlatinib for patients with ALK mutation, and her discussion today will be on targeted therapy on ALK mutations and other possible targeted therapies. Dr. Kelly Goldsmith.
Thank you so much, Pat, and good morning to everybody. It's so nice to see you all. So I want to thank Pat and the organizers for inviting me to come give this talk to you guys, and I hope that by the end of this session, you'll have a little bit more understanding of some of the more common alterations and how to target them in neuroblastoma. So for this talk, I'm going to give you an overview of the most common tumor types that we treat initially with these targeted therapies, being recurrent and refractory high-risk neuroblastoma. We'll talk about therapies targeting genetic alterations in this tumor, which will include the results of our lorlatinib phase 1 trial that Pat mentioned. We'll talk about the role of circulating tumor DNA and tracking responses to targeted therapies. And then we'll talk about targeting tumor heterogeneity, which I'll tell you about in just a minute and define it, and overcoming targeted therapy resistance. So, as you all very well know, high-risk neuroblastoma patient outcomes, while they continue to improve, we still have a subset of patients who either don't respond to upfront standard therapy or their tumor comes back during therapy or afterwards, either right afterwards or even sometimes a long time after. And I wanted to kind of help you understand the difference between refractory and relapse disease, and these are really the patients that we're trying to find better therapies for. And as we find better therapies for our high-risk recurrent and relapsed patients, we actually pave the way to introducing new therapies to our newly diagnosed patients to try to prevent this from happening. So refractory high-risk neuroblastoma is really patients whose tumor does not respond completely to upfront high-risk induction chemotherapy. And relapsed high-risk neuroblastoma is when the tumors grow back in same or different locations, and they can occur anytime during or after upfront high-risk therapy is completed. So tumor sequencing of both diagnostic and relapsed neuroblastoma tumors has done an amazing job to help us identify new druggable targets in this disease. So prior research has shown that patients with newly diagnosed neuroblastoma really have mutationally quiet tumors. In other words, they don't have a lot of targetable genetic alterations at diagnosis. But what was elegantly studied and shown in these two Nature Genetics papers back in 2015, when they looked at diagnostic primary tumors and relapsed primary tumors, was that patients with recurrent high-risk neuroblastoma had increased number of mutations and different genomic mutations that might be targetable with unique therapies. And this led to the identification of ALK being enriched in relapsed and recurrent neuroblastoma. And we're lucky for that because the adult cancers also have ALK genetic aberrated tumors, and so there were ALK inhibitors already in the works for adult tumors. And other mutations in other pathways, such as the RAS and MAPK pathway tumor mutations, were also increased in patients with relapsed tumors. And there are new generation RAS inhibitors that are currently under investigation, but the inhibitors that are well known that are downstream of these mutations are MEK inhibitors, such as erlotinib and cobimetinib, as a couple of many examples. So let's talk about targeting ALK in neuroblastoma, because I'm sure a lot of you have heard of the ALK gene as you've been undergoing this with your children, both at diagnosis and recurrence. So ALK is called the anaplastic lymphoma kinase gene. It was first discovered in neuroblastoma by Yael Moshe, where she discovered that patients who had a predisposition to develop neuroblastoma, so had a mutation in every cell of their body, that ALK mutations were the most common mutation in patients predisposed to develop neuroblastoma. That's only in 1 to 3% of patients. But then what she also found was that ALK was actually mutated in tumors that in patients not predisposed to developing neuroblastoma. So 14% of newly diagnosed patient high-risk tumors will have ALK mutations. That doesn't mean they were prone to developing neuroblastoma. It was just called kind of a somatic mutation, tumor-specific mutation. And as I mentioned, at recurrence, there's about a 30 to 40% of these tumors that have ALK mutations. And so this led Dr. Mose and others to really investigate what is the utility of ALK inhibitors in neuroblastoma. And so there was a phase 1 and 2 trials run of the first generation ALK inhibitors, such as crizotinib, in children with refractory and relapsed ALK-driven solid tumors. So there are other pediatric tumors that have ALK alterations. So anaplastic large cell lymphomas also have ALK alterations, and inflammatory myofibroblastic tumors did. And their response rates were pretty remarkable. About 90% to 86% of those patients with those recurrent tumors responded to these agents pretty remarkably. But the neuroblastoma patients really didn't have such a great response to first-generation ALK inhibitors. And what was understood later on is that it's because the ALCL patients and the IMT patients had what's called an ALK fusion. It's a different genomic alteration than neuroblastomas that have what's called a missense mutation or an ALK mutation. And the ALK mutations are inherently resistant to first-generation ALK inhibitors. There were second-generation ALK inhibitors that came along to overcome resistance to the first-generation ALK inhibitors, such as ceritinib, and a phase 1 trial of that agent was run in children with ALK-driven tumors as well. And the neuroblastoma patients still didn't have the best response rates. Only about 20% had a response to these second-generation inhibitors. And unfortunately, really responses, while they were good, were only limited to patients with a certain ALK mutation, only one of the 3 most common hotspot mutations in neuroblastoma, being the ALK R1275 mutation. And so, as I mentioned, it became clear that several neuroblastoma, what we call hotspot mutations, meaning the most common mutations we see that activates this protein in these tumors, are intrinsically resistant to first and second generation ALK inhibitors. As you can see on the, I'm trying to see if I can make this work. On the right is some animal studies showing that patient-derived tumor grown in a mouse, the black line is just the tumor treated with really nothing, and it just continues to grow over time. The line shows tumor growth over time in the blue line, which is with crizotinib at 100 milligrams. And then the red line is testing this new agent called lorlatinib, which is a third-generation ALK inhibitor, in mice harboring these very resistant ALK-mutated tumors, and they have a complete tumor regression that's sustained with the treatment. And I don't know if you can see it, but the dose is 10 milligrams compared to the crizotinib dose of 100 milligrams. So it's a very potent ALK inhibitor. So what is lorlatinib? So it's a third-generation ALK inhibitor. It targets neuroblastoma-specific mutations. So Pfizer actually developed this drug to overcome mutations that arise in lung cancer patients when they become resistant to first and second generation ALK inhibitors like crizotinib and ceritinib. Amazingly, those mutations actually happen to be the mutations that happen in neuroblastoma from the get-go. And so lorlatinib seemed like a really great option for our patients because it really targets the mutations that arise in our high-risk neuroblastoma kiddos. And so it targets these mutations. The other great aspect is it crosses the blood-brain barrier very well, and that's important in lung cancer patients who get metastases to the brain. We also know, though, and I know Dr. Kramer's going to talk about it, that we get CNS relapses in neuroblastoma. So again, we thought this is a really great opportunity to try this drug that might have an effect on ALK-mutated tumors that might cross over and be in the CNS. And patients with ALK amplification, which have a very poor prognosis, also are responsive to this agent. So this led Dr. Mose and I to run the NANT 1502 trial, which is a phase 1 study of lorlatinib in patients with refractory and relapsed ALK-driven neuroblastoma. So the goals of this trial were really to determine the toxicity profile in pediatric. It's a first-in-child study of lorlatinib, to really understand what's the best dose to use in our patient population, because it could be different and often is very different than the adult dosing, and to really see how does lorlatinib work with chemotherapy. Does it have more toxicity? Does it have a better effect? And so we looked at it both alone and with chemotherapy being topotecan and cyclophosphamide. And we also, interestingly enough, there are patients, adult patients, that have high-risk neuroblastoma that recurs. And so we specifically looked at pediatric population and the adult population with recurrent neuroblastoma. We also took this opportunity for the first time to really investigate what is the role of circulating tumor DNA in patients with a targetable mutation that we're using a targeted agent for. So one of the goals was to determine the overall frequency of that circulating tumor cell-free DNA and profile for tumor-specific mutations, to follow the ALK mutations over time, and to look and see if we could identify mutations of response or relapse or resistance to our ALK inhibitor specifically. So I'll tell you a little bit about the results of this trial, which we published earlier this year. We were very pleased to see that in terms of hematologic toxicity, meaning what happens to the blood cells with this drug. We know chemotherapy knocks blood cells down. We know that certain targeted therapies even suppress the bone marrow. Unlike first-generation ALK inhibitors like crizotinib, which does affect the blood counts, lorlatinib in the lung cancer patients, in adults, did not. So we were very excited to see if this was the same case, and indeed it was. So we found that there was no hematologic toxicity from lorlatinib when it was given alone. And in addition, it didn't increase the hematologic toxicity that we see with chemotherapy when lorlatinib was combined with chemo. So that was really exciting in terms of thinking about moving it forward to use for our patients, maybe with a standard of care approach later on. The common non-hematologic toxicities were exactly what they saw in adult patients, which was weight gain, pretty significant weight gain, increased cholesterol, and increased triglycerides. What we did find over the course of watching our patients and learning how to treat them while on lorlatinib, we found, just like the adult patients, weight gain and increased blood sugars that occurred in some patients that were a little bit more predisposed could be easily controlled with diet and exercise alone. And high cholesterol and triglycerides, we had a profile of different statin agents that we could use, and they could be well controlled on statins, which are HMG-CoA reductase inhibitors, or the typical cholesterol-lowering agents that a lot of adults get on for high cholesterol, and it's the #1 drug used for children with hypercholesterolemia. Rare toxicities were attributable to the high blood-brain barrier penetration of lorlatinib. This was very similar to what was seen in adults. Were what we call neuropsychiatric side effects. Importantly, this only really occurred in patients greater than or equal to 18 years of age, so not really our typical target population who have high-risk neuroblastoma or recurrent neuroblastoma. But it's important to understand how this affects, because we wanted to make sure that there were no untoward toxicities towards our patients if we move this into the upfront setting. And so some of those specific CNS toxicities were like memory impairment, mild cognitive changes. We actually had iPads that we did cognitive testing every single time they came in. And psychiatric symptoms, some patients had a little bit of delusions and hallucinations. Again, these were our adult patients, very similar to what was seen in lung cancer patients. And the worst CNS side effects that we saw were actually limited to patients who had a predisposing history of psychiatric illness. And so we actually amended the protocol to say, to really make sure we took good histories, and if you've been hospitalized or had any kind of depression, needing medication or anything like that. So these are really more adult psychiatric issues versus, let's say, a kid with ADHD. That's not a psychiatric issue. That's not what we're talking about here. So those were the only patients that really had a significant side effect, and then the therapy was stopped and not restarted. And that only happened in 2 out of the entire patients who were older than 20 years of age. So based on these toxicities and the response profile that I'll show you in just a minute, we did come up with the recommended phase 2 dose. For patients greater than 12 months of age and less than 18 years, the dose was 115 milligrams per meter squared. And I'm mentioning this because this is actually 200% of the adult dose, and we'll talk about that in just a minute. In patients greater than 18 years of age, we came to the decision that 150 milligrams was both tolerable and showed better responses. And so I wanted to take a second to tell you, why did we jack up that dose? Well, it's not uncommon in pediatrics that we use higher doses in children of the same drug that's used in adults, and that's often due to metabolism, how it distributes in the patient's body compared to an adult. But here, this really goes back to what we saw in the laboratory in Dr. Yael Mose's laboratory, and we also talked with our collaborators at Pfizer, who are our pharmacology MDs. And what we found was that our tumors that have these ALK mutations are very similar to lung cancer tumors that have not just the ALK fusion, but develop a resistance mutation on top of that ALK fusion that mimics the neuroblastoma. And those actually do require higher doses of lorlatinib in the adult lung cancer setting. And so neuroblastoma really more mimics those more resistant lung cancer patients. And that's why the dose is necessary to truly target the full-length ALK in our patients to have an anti-tumor effect. And so we're not just jacking up the dose till we think, it's too intolerable. There's actually a real scientific reason why we did that. All right, so let's talk about some responses. So the single agent response rate in patients greater than 12 months to 18 years of age was 30%, and this includes complete responses, meaning all the tumor goes away, partial responses, you have a really good response, but not everything goes away, and what we in NANT call the minor response, meaning we have sometimes a complete response in one area, like all the bone disease goes away by MIBG, but then you have stable disease in the tumor in terms of its size. So it's no longer metabolically active, but the tumor is kind of still sitting there, but doesn't show up by MIBG. And I'll explain why these minor responses are important in a minute. For patients greater than 18 years of age, the response rate was 67%, and in combination with chemotherapy, the response rates in patients less than 18 years of age was 63%. And if you look over to the right, that's just showing you, those lines tell you how long the patients remained on study, and I'll draw your attention to some of the yellow lines. So that's actually just what we would call our standard stable disease, meaning the patients either responded a little bit or didn't really respond but didn't get worse, but they remained on this therapy with a great quality of life for a very long period of time. So we do believe that lorlatinib is benefiting those patients as well. And I forgot to mention that we did allow patients who were pre-treated or had seen treatment with crizotinib and ceritinib, and they had responses. All ALK hotspot mutations had responses as well compared to the earlier generation agents. And interestingly enough, we had one patient with a germline mutation who happens to be that line at the very top in only dose level 1, and they had a remarkable response. And this is in keeping with the earlier ALK inhibitor generations, that patients who have a germline, meaning all the cells in their body have an ALK mutation, so they're predisposed to develop neuroblastoma, are exquisitely sensitive to these ALK inhibitors compared to other patients. And so I wanted to just show you, can I go back? Yes. So I just want to show you what is important about these minor responses. So if you look at the top lines, those are scans of showing you the best MIBG response. So it's from their baseline MIBG to how much it decreased over time. And so the left graph is showing you the patients getting lorlatinib single agent therapy that are less than 18 years, the middle is greater than 18 years, and the right is with chemotherapy. And if you look at the yellow lines, stable disease, the majority of the patients with stable disease actually had a complete MIBG response, meaning that their MIBG went completely away. It went negative, but their tumor didn't change by RECIST criteria. And so these patients were benefiting and were showing an anti-tumor response, but not in the way that we conventionally monitor tumor response by, did the tumor shrink by MRI? And so what we can say just anecdotally is Dr. Mose did biopsy a patient who had a complete MIBG response and had been on lorlatinib for a very long time in stable disease, and it actually, the tumor was differentiated. It was no longer a neuroblastoma. It looked like a ganglioneuroma, which is a benign tumor under the microscope. So we think this may be what's happening. I cannot tell you this is what's happening to every tumor of a patient with stable disease. And did some of these patients' tumors recur? Yes, they did. So I'm just giving you one example, but that's anecdotal. So here's an example of what I was talking about. This is a patient who had a, this is a hard pointer, who had a tumor over kind of in the little left carotid area that encased their vessels so they couldn't take it out. And it really didn't change in size from the beginning to course 4. But if you look at the MIBG, see how bright it is right there? Now salivary glands naturally light up, so those two on the sides are normal. But if you look at that, now look what happens. It completely went away by MIBG in course 4. This patient actually continued to have MIBG negative disease and had been treated for, I believe, 3 years, 2 years on study, and then came off study to continue commercial supply, and is currently with no evidence of disease. And so let's talk about circulating tumor DNA and how it might inform responses to targeted agents. So what is circulating tumor DNA? It's tumor-derived fragmented DNA in the blood that is not associated with cells. The exciting aspect of this is that samples from the blood can be taken out and the plasma can be separated out, which is the yellow liquid part of the blood apart from the blood cells, and that DNA hangs out in that plasma. You can take that circulating tumor DNA and look for tumor-specific mutations over the course of therapy. And as we all know, for solid tumors, we're not as lucky as leukemias. We can't just sample the blood to see if the leukemia is there, and biopsying isn't necessarily feasible in every situation for our patients. So could this be used to actually track our patients' responses over time and to look for evidence of new mutations that might confer resistance? So these efforts were led by Dr. Esther Burko, who was formerly at CHOP, and she looked at the circulating tumor DNA in our patients that was taken at baseline with every disease evaluation and at the progression of disease. And she identified that there were really 3 trends or categories that our patients fell into on this trial. About 50% of the patients, the ALK ctDNA mutations completely correlated with clinical response. It was high, it went down, and you could see on the scans that the tumor was going away. When the tumor looked like it was coming back, the ALK mutations were coming back. ALK and the ctDNA in other patients and clinical response actually did not match. So for example, that was in about 1/3 of our patients, where she saw a decrease in ALK mutational burden over the course of therapy. However, the tumor came back. But if you look at the tumor ALK ctDNA, what you will notice is while the ALK mutations aren't there, there's new mutations that are arising. So more than likely, we're seeing an outgrowth of tumor on the scans that is no longer ALK mutated because the ALK inhibitor got rid of the ALK mutated tumor, but new tumors growing that didn't have ALK mutations and has different mutations. That's why the circulating tumor DNA, specifically looking at ALK mutations, were not present. And then in a 3rd category, there are about 8 patients where the ALK mutations were not even detected at baseline in the circulating tumor DNA. We don't have an answer to this. My patient was one of those patients. She did have an ALK F1174 mutation at diagnosis in her tumor, but not in her plasma. And the majority of those patients all responded to therapy. And they did come back, and the ctDNA, when they progressed, did show ALK mutations. So another really exciting thing that we were able to identify were new mutations that told us what possibly could be causing their resistance to the lorlatinib therapy. And this, again, really, I want to highlight that on the left side, it kind of gives us an idea of why we may not want to give lower dose lorlatinib compared to the dose that we picked as our recommended phase 2 dose. So in some of the earlier dose levels, what Dr. Burko identified was when their tumor came back, not only did you see the ALK mutation that was in their circulating tumor DNA and their tumor at diagnosis, but now there were new ALK mutations. And this was really specific to those patients on the lower dose levels of lorlatinib. We can't explain why, but they're called compound ALK mutations. This actually was seen in lung cancer patients as well. So this is a common occurrence of resistance to lorlatinib. On the right side is really showing you the patients from baseline going over to when they have progressive disease. The different courses are on the bottom. And what this shows is that along with some ALK compound mutations that arise when the patient's tumor starts coming back, we see new mutations arise, and specifically in the RAS and MAPK pathway. And so this really goes along with what we were seeing as a response to standard of care therapy, that these RAS mutated neuroblastomas are pretty aggressive. And so despite seeing these mutations arising in resistance, these were pretty impressive responses for a phase 1 agent to a single drug given once a day by mouth. So it was really exciting and compared to the earlier ALK mutations. And so this led to a rapid translation of lorlatinib to replace crizotinib in the active and enrolling COG phase 3 trial, AMBL 1531. So an amendment was written and Pfizer agreed, and we worked together to transition patients who were on crizotinib to lorlatinib, and then the new patients who were found to have an ALK mutation at diagnosis were started on lorlatinib and along with standard of care chemotherapy. This trial is still ongoing, and I believe we've enrolled about 20 patients on this arm since we've started lorlatinib, and so we're very excited to be able to offer this to our newly diagnosed high-risk neuroblastoma patients, because we know, and I didn't mention it, but if your patient has an ALK mutation at diagnosis, they have a little poorer prognosis, and so we want to be able to offer them something to really improve their chances of cure. We also had an international collaboration, and these two transitions into these high-risk trials were supported by Solving Kids Cancer, and what they really encouraged and what we've done beautifully is collaborated to align our two high-risk studies from here and across the waters in the SIOPEN high-risk neuroblastoma 2 trial to include lorlatinib in that arm. They haven't opened it up yet. They're working with contracts, but that's the goal, is to have similar statistical designs, similar CNS evaluations, and to make sure that we are really accounting for what could be possible CNS adverse events or side effects of lorlatinib when given with standard of care chemotherapy for newly diagnosed high-risk patients. So I also wanted to mention that the Children's Oncology Group also has a match-type trial that is available for patients with solid tumors and lymphomas. It's called the COG-NCI match. And what they do is a tumor biopsy is done, and they do next-generation sequencing of patients' tumors, like that's how we discovered ALK in neuroblastoma. And when they do, they identify whether the patient has a specific mutation that would allow them to enter or enroll on a sub-study trial of a targeted agent. The current pediatric match sub-protocols are all single-agent therapy for patients with recurrent or relapsed disease. This is not for newly diagnosed patients. But in red, I wanted to circle some of the agents that are available on these match trials that target specific alterations in high-risk neuroblastoma. Most of these trials are complete, and in talking with Julia Glade-Bender, who is at Sloan, who is now in charge of the new match trials, they're going to be moving forward with combination therapies for patients with newly diagnosed, for relapsed high-risk tumors, which would include neuroblastoma. I don't know what those combinations are yet, though. So MYC-in, I'm sure you've heard, MYC-in amplification, even if you have a single tumor that's not resected, kind of pushes you up to a high-risk status in terms of risk classification. And it's amplified in about half of our patients with high-risk disease. So why don't we just target MYC-in with a MYC-in inhibitor? You can't. They don't exist. MYC-in is what's called a transcription factor, and transcription factors are very difficult to just target. ALK is different. It's a tyrosine kinase. It continues to signal, and we hit that signaling domain. So how can we think about new and exciting ways to target MYC-in amplified tumors? And I'm just going to go into a little bit of the science. Bear with me. I'll try to be real quick so I don't bore you. But I don't know if you remember back in science days, high school, college, or if you did a little biology further than that. A gene is really DNA. It's made into RNA. The RNA is made into protein. And eventually, that protein can't stick around forever, and it's kind of tagged to be degraded over time. That's the life cycle of a gene to a protein. And so the MYC-in is amplified, so the gene itself has a lot of copies. And so there are efforts to really try to prevent this MYC-in gene from becoming RNA to make it into a protein. And so there are methods that people have tried to do to target the machinery that's responsible for making this gene into RNA. And so there are these proteins called BRD4 that bind with a lot of other proteins that actually are the transcription factor that turns on the transcription factor known as MYC-in. And so there are BET inhibitors or BRD4 inhibitors. There is a trial open at Boston of a BRD4 inhibitor for relapsed solid tumors, and it is enrolling. There's other proteins such as CDK7, which binds with this complex, and there are things called CDK7 inhibitors. There are some people at Boston who are looking to combine preclinically CDK7 inhibitors and BRD4 inhibitors, and there's been some publications of that, but it's not in a clinical trial yet. There's other agents that are responsible for other aspects of the gene being made into RNA being made into proteins such as the CDK9/2 inhibitors, but again, those are just in the lab right now. So once that RNA is made into a protein, how does that protein eventually go away? So there are proteins out there that help stabilize MYC while it's doing its job, preventing it from going on and being degraded like it normally would be. Those proteins are known as Aurora A and PLK1. And the job of those proteins is to stabilize MYC, keep it doing its job by preventing this gray protein called FBXW7 from binding to MYC and tagging it for degradation. And so what PLK1 and Aurora A do is they inhibit that agent called FBXW7, and MYC can keep doing its job, which is not good because it's an oncogene and it drives neuroblastoma. It's one of the most driving oncogenes there is. And there are Aurora A inhibitors. There are Aurora A and B inhibitors. I don't know if Araz is going to talk about that, but there were trials run through the NANT of a drug called alisertib and erbumine, and those have been completed. Some are already published, and one is not yet. There are also PLK1 inhibitors that people have been looking at from a preclinical standpoint, but I won't go into too many more details since Araz may talk about NANT stuff. So how can we target MYC indirectly? That's really the way that a lot of research is going because MYC is so hard to target directly. And so there are downstream targets of MYC, and I'm sure you have heard of them, and I know Dr. Brown may be talking about this a little bit more in detail from a different venue. But MYC is known to increase a protein called ODC1. And ODC1 helps make these building blocks of the tumor cells called polyamines. So there's a drug called DFMO, or eflornithine, that inhibits ODC1, and by doing so, it can kill neuroblastoma cells. In the NANT, we have shown that high-dose DFMO in combination with chemotherapy is safe and tolerable, and that data will soon be published by Dr. Hogarty and the NANT committee. But what Dr. Hogarty's lab also has shown in conjunction with his collaborator, Dr. Basiri, is that ODC1 and MYC, downstream of those polyamines is this other protein called arginine. And arginine is known to be very immune suppressive. It suppresses immune cells. And so DFMO, by inhibiting ODC1, it inhibits arginine, and those immune cells wake up. And so what he's shown is by using DFMO that you actually see increased immune cells, increased good cytokines. And so it made us think, well, is there a role for DFMO in combination with immunotherapy in neuroblastoma? I know you guys got an earful on immunotherapies yesterday. And so we all know that everybody's working really hard from the research, clinical and preclinical side to really improve how this chemoimmunotherapy works. And so this led Meg Macy and myself to propose ANBL 1821, which is a randomized phase 2 trial of dinutuximab, irinotecan, and temozolomide with and without DFMO in patients with relapsed and refractory neuroblastoma. It's actually currently open and enrolling at the majority of COG institutions. And we're really trying to understand, does DFMO improve dinutuximab and chemotherapy response by inhibiting polyamines and activating patients' immune cells, which are needed to respond to dinutuximab. So DFMO is given daily for 28 days, but because it's high dose, we give a 1-week break to avoid ototoxicity because they can have hearing loss from high-dose DFMO. And irinotecan and temozolomide and dinutuximab are given like they're normally given over the course of that 5-day period. And we are testing patient samples in my lab for immune cell changes in response to DFMO, a 1-week lead-in, as well as during the course of therapy to understand biomarkers, immune biomarkers of response. And Dr. Reynolds, who'll be talking to you later, is evaluating patient bone marrows and blood for GD2 tumor expression as well. So I wanted to take a step back. There's a lot of really exciting targeted therapies, including lorlatinib, that are there. We're all trying to investigate and identify new ones as well. And there are challenges. So relapsed and refractory neuroblastomas are really chemotherapy resistant. And neuroblastomas are what we call heterogeneous. Not all tumor cells within the same tumor in the metastases actually have that gene mutation like ALK, or express that cell surface protein like GD2. So can we identify new tumor-targeted therapies that might have a better way of killing off all of those cells? Should we combine our targeted therapies with chemotherapy so that we can have the targeted therapy kill the ALK-mutated cells while the chemotherapy is acting on those cells that may not be ALK-mutated, or in combination? And as we've heard, and we'll continue to hear, that can we give immunotherapy to overcome those tumor cells that are not mutated? So I'm just going to take a brief moment just to talk about some new things that are going on at our institution to maybe address neuroblastoma heterogeneity. So as you all know, immunotherapies can kill tumors regardless of tumor-specific genetic mutations. And so CD8 T cells require chimeric antigen receptors to be able to activate and kill the tumor cell. So most use patient-derived CD8 cells because if you don't, these CD8 T cells could cause GVHD if you got them from a healthy individual. And along with that, there has been research to show that neuroblastoma patient T cells are very tired, even at diagnosis and then after chemotherapy. And these are the cells you're using to give back to the patient after you expand them, engineer them, and put them back in the patient. So they may not be as robust as healthy donor cells. Not all tumor cells express the CAR target of interest, so you are limited of that CAR T cell targeting only those tumor cells that express that antigen. And the tumor microenvironment suppresses those immune responses. So we've been looking at another immune cell subset called gamma delta T cells, which are a lot like NK cells. They're already armed and able to kill the tumor cell without any genetic engineering. They are actually able to improve antibody killing because they have high expression of this antigen called CD16, which is on the surface of the cells and necessary to recognize dinutuximab-coated tumor cells. They are not reliant on MHC, so they actually do not cause graft versus host disease and offer the ability to give an off-the-shelf allogeneic product. And I know that that is also a possibility with NK cells that I think either they talk to you about or are going to talk to you about. Araz may mention that as a future study in NANT, the NK cells. And that's really a focus. The other thing that's really great about these gamma delta T cells is they can recruit and activate other immune cells. So even if you engineer these guys to recognize a tumor antigen, they can recruit other cells to kill all the tumor cells. Interestingly, there's been studies shown that when you have tumor-infiltrating immune cells, just when you take out a tumor and look at what's making up that tumor besides the tumor cells, they're actually immune cells that sit there. Most of the immune cells are suppressed. But what they showed was that if you have gamma delta T cells in your solid tumor in a huge category of different tumor types, that the number one immune cell that was associated with an improved prognosis with the gamma delta T cells in those tumors. And so can you run that video real quick? I'm a visual learner, and so this is kind of fun. So we treated some neuroblastoma cells with dinutuximab, and then we came back in with these blue gamma delta T cells. So the green cells are the neuroblastoma cells. And as you can see, these are unengineered, unmodified, just expanded gamma delta T cells. And you can see the green cell blebbing. It's about to pop. And the other one on the far left just completely got killed. And so that's what gamma delta T cells do to neuroblastoma cells. And those are human-derived gamma delta T cells from an allo product, and that's a human-derived neuroblastoma cell. So kind of fun. I like showing that. So we took these gamma delta T cells, combined them with dinutuximab and temozolomide in a mouse, and showed complete tumor regression, which is that red arrow, in very aggressive mouse models of neuroblastoma. We also think that adding zoledronate in combination with this chemoimmunotherapy and cell therapy might improve gamma delta T cell therapy in the patient, because zoledronate is actually what we use to selectively enrich for gamma delta T cells outside the body. It's a bisphosphonate that's safely used in neuroblastoma patients, and it sticks around for a while and can also help the gamma delta T cells home to bone sites of the tumor. And so we looked, should we use autologous gamma delta T cells? And long story short, because I don't want to go over, I want to give you guys time to ask questions. Gamma delta T cells make up a very tiny percent of the immune cell population in a person. And patients actually undergo apheresis already for standard of care. And we always have what I call rainy day bags of stem cells. We've been able to expand gamma delta T cells from patient-derived apheresis products. But because these gamma delta T cells are from a healthy donor, we think they'll be better given that neuroblastoma apheresis products are in high demand. We're now giving MIBG up front. We're giving 2 tandem autologous stem cell transplants. We're not going to have a lot of apheresis products, and putting a patient under apheresis again is a lot to ask of a patient, especially at the setting of recurrent and relapse disease. So we think that a healthy donor product will allow us to give more infusions and a stronger product. And so this led us to propose a phase 1 study of ex vivo, meaning outside the body, expanded allogeneic, which means healthy donor, gamma delta T cells in combination with dinutuximab, temozolomide, irinotecan, and zoledronate in children with refractory relapsed high-risk neuroblastoma. And so our goal, it's an AFLAC investigator-initiated study that I'm the chair of. It's open to enrollment. It's currently a single institution. We hope to expand it past this, is really to determine what our recommended phase 2 dose of the cell therapy product will be in combination with this chemoimmunotherapy and zoledronate combination, what the toxicities are, as well as what the responses are. We're also going to be doing some immune profiling to see how these gamma delta T cells, if they do indeed wake up the patient's innate immune cells while it's also fighting the tumor itself. So we're really excited about this trial and are excited about enrolling some patients on it. So in conclusion, I hope I've shown you that drugs targeting neuroblastoma specific mutations can be very effective if they're targeting a genetic driver mutation like ALK. Lorlatinib shows a strong promise against ALK-positive neuroblastoma and is now being looked at in the newly diagnosed setting. Serial circulating tumor DNA can be used to track responses and identify emerging resistance mutations to targeted therapies like lorlatinib. And we can use ctDNA results for clinical decisions, but really what the utility of that is still under investigation in terms of in the setting of not having a targeted therapy or a targeted mutation specifically to follow. Drugs indirectly targeting MYC and gene expression, protein stability, and downstream targets are still being investigated, but we're learning sometimes it doesn't carry over into the patient to have the same effect as we see in terms of targeting MYC and amplified tumors specifically. And other targeted agents I didn't talk about that I believe Uraz will probably talk about, such as MIBG therapy, which truly does target neuroblastoma as well, will probably be discussed in upcoming talks. New cell therapies derived from healthy donors, such as allogeneic gamma delta T cells and NK cells, have innate tumor-killing properties without being engineered and may help overcome this solid tumor heterogeneity because they don't just target the tumor antigen-expressing cell, they target all of the cells. Every child with relapsed and refractory high-risk neuroblastoma is unique. I can't stress that enough. What works for one patient may not work for another patient. The first choice and the next choice, and the next choice for relapse therapy, because we know we often go one to the next, is really based on how the patient's doing, their genetic alterations identified, which it's very important to look at relapse, what those genetic alterations are, not from the diagnostic tumor when you're trying to treat your relapsed child. And trial availability and prior responses and toxicities on upfront or other relapse therapies are very important to consider when thinking about that next best treatment to our goal, which is ultimately to cure all of our patients. So I'd like to thank you guys, and I'm open for questions, and especially to thank our patients and parents who we would not learn anything without you guys enrolling on our trials, benefiting from the therapies, and we benefit from you as well so that we can continue to move this forward to improve our responses. So thank you.
Thank you. Does anyone have any questions? No? Nothing to, oh, okay, we've got a few of them starting
Okay.
here. Here we go. We'll do one here and then one over there, and then we'll do you.
If you're allowed to share, Margaret from Tennessee, my daughter was treated at Vanderbilt. The clinical trial that you did with Dr. Macy, are you allowed to share what results you've noticed so far? No. When do you think that will be published?
It's an ongoing trial.
I know.
We actually don't get the responses.
We were in it, but we didn't get the arm with DFMO, so I'm just very curious.
Sure.
How long, is there even a guesstimate of when those results would be published or out?
That's a great question. So we've had some opening and closings based on just some drug and shipment availability of the DFMO, and so it was delayed initially, but now we're back on track. And once we're on track, we usually enroll pretty well. So we anticipate that we'll be done with enrollment by probably early 2024. And based on that, then the responses usually come, the results come later. It just really depends on how quickly we have central review of responses, and that takes some time as well. So sometime in 2024. Yeah, and unfortunately, they don't share it with us either. It's everything's blinded to us as well.
Okay. We had one more back there.
Yes.
Hey, okay. I know the DFMO, the high dose with, chemoimmunotherapy, it's not available for relapse patients who have already had chemoimmunotherapy. Is that right?
No, they
So
can
the-
have it. They just couldn't have progressed on chemoimmunotherapy, I believe. Or wait, no, they can't. Yeah, it's first relapse. So yeah, you're right.
Right.
They can't.
And
Usually when we have that, they can't have progressed through it. They can't have progressed on dinutuximab during induction therapy. Sorry. Thanks, Ross.
yeah, so is that the same for the gamma cells? Like if you've already had chemoimmunotherapy, could you enroll on the trial for the new gamma T cell?
The gamma delta T cells?
Yeah, yeah.
I believe you can't have progressed through it. I'll make sure. But yes, you can have seen it before. You just can't have progressed on it.
Okay.
So if you had it, switch to another therapy for one reason or another, but if your disease progressed on or shortly after that, then you're not eligible for
Right.
it. But if you've had it before, yes.
You could still get the gamma T cell. Okay,
Correct.
thank you.
Yeah.
Okay, we have a question.
Two quick questions.
Yes,
One,
ma'am.
how common is it for a patient who wasn't diagnosed with the ALK mutation at diagnosis to then at relapse have the ALK mutation? And then two, you spoke about ODC1 and its relationship with polyamines. So Ella was on the ANBL 1821, did very well. But the question is always, what role, if any, does diet and low polyamines diet play when taking something like a DFMO?
No, they're very good questions. So to answer your first question, if you think about it, newly diagnosed patients, about 14% have ALK alterations, and then about 30 to 40% at relapse. So there's definitely more that are going to have it at relapse. So if you didn't have it at diagnosis, I would definitely check at relapse. I think we're going to get more sophisticated with time. I didn't mention, but we did not make eligibility based on circulating tumor DNA, right? We made it based on the tumor-specific mutation, and it could have come from patients from a diagnostic tumor to a relapse tumor, because we definitely know that patients who have it in the beginning usually have it at relapse. It's just there are some that do emerge over time because we're probably killing the less resistant cells with our upfront therapy and allowing those ALK mutated cells to now take over. So there was data to show that there were what we call subclonal ALK mutations that probably weren't picked up by the earlier sequencing that we used that we're now seeing. So there's a possibility that there were a couple of cells there to begin with. We're going to get more sophisticated in terms of being able to dive deeper into our tumors with our next generation sequencing to identify those. The role of lorlatinib in patients with subclonal ALK, we don't know yet. And so we still need to understand that and investigate that a little bit more. But I do believe we will follow the Pfizer bandwagon later on, in that at relapse, if you do see ALK alterations in the circulating tumor DNA, do you really need a biopsy to be able to put a patient on lorlatinib? And they are allowing circulating tumor DNA now. And I remember when they were starting to compare, what does the tumor look like? What does the circulating tumor DNA look like? And then they were able to move over. I have a feeling we'll go there. And there's been, including Dr. Mose and others, they've created these very deep sequencing circulating tumor DNA panels to really identify that. It's just, what's your cutoff? What's your ALK mutation frequency that we will allow for that? So that hopefully answers your first question. Your second question, we don't feel strongly that a diet, low in, arginine and things like that and polyamines really will affect your tumor. It's kind of the same thing as what we see with adults trying to modify their diet to treat their tumor or to prevent it from growing more. So we don't require that. I think the best thing to say is you need high-dose DFMO to really inhibit all polyamines. And so to think you can do that with your diet is probably not possible. And so that's why we know low-dose DFMO really doesn't have a role, and high-dose really seems to have an effect, but we have to make sure that we're careful to monitor for the toxicities that you can see, because DFMO does affect your ear. It's reversible, but the higher the dose, the more it affects the cochlear area. So
Okay,
it's a
one
good
more
question.
question?
On all the kids that you're treating for, or monitoring for ALK, for your ALK treatments, are all of them being closely monitored with liquid biopsy?
That's a great question. So for us, yes, they are. I mean, for my institution, we do. I know a lot of people are jumping on that bandwagon to do it. If they have an ALK alteration, most people will get that because it's a very nice, non-invasive way to look. We constantly will revisit, okay, do we act on this, right? So if you see an ALK mutation coming up or a RAS mutation coming up, but the patient's doing well, I don't think any of us would just stop the lorlatinib, and we would wait to see if they have a radiologic progression. And there's a couple of reasons for that. I don't think we understand completely the circulating tumor DNA and at what point does it truly predict a progression or a relapse. As I mentioned, there were those three categories, right? Even on lorlatinib, sometimes the circulating tumor DNA did not predict the disease progression for different reasons from an ALK mutation standpoint. But the other reason is if you stop lorlatinib, even if you are starting to progress on it, the adult world in lung cancer has shown us that you actually can get a more rapid progression. So sometimes we will monitor it on lorlatinib and not bridge too long off of an ALK inhibitor before you go to that next therapy to prevent the tumor from progressing even more quickly, because you kind of have a stop on it. And you remove that eraser and it just is going to start taking off, even if it's starting to slowly progress on that drug. So we don't really want to just stop it without a plan. And so actually a lot of us when we were having patients on crizotinib and ceritinib who were transitioning over to lorlatinib on the phase 1 trial, the pre-treated patients, our window of what we call the washout window of how long you have to be off of a therapy was very short. Whereas it's usually like 2 weeks to 21 days, it was like 6 days. And so we made it very quick because of the experience Pfizer and the lung cancer oncologists had with patients being on these targeted ALK inhibitors. So, but we do like to follow them. And there's lots of different ways that you can do it. There's commercial ways, and there's other clinical testing.
Thank you.
Yeah, absolutely.
All right.
Yes,
And
ma'am.
last question?
Hi, sorry. So I'm intrigued, and I'm like, with the 1531 that has like all the different arms, and being able to see that ALK arm, not only because it's going to be more beneficial for, kids with that ALK mutation expression to be able to receive that lorlatinib up front, but it also means that sequencing is taking place at diagnosis. So, we did Frontline in 2014. That was not an option. That was not something we ever did. We didn't get any testing done until, tumor resection for, 4 cycles in. And by that time, we didn't have a lot of information because it was pre-treated. And even when we relapsed 7 years later, 7 years after initial diagnosis, I had to advocate a lot. I asked a lot of questions of how do we get some genetic testing done? How do we do this? How do we, And I feel like my son was failed. It took 13 months of advocating to finally get a test done, which ended up being the ctDNA test because of the power of parents and networking. So I guess my hope is that with this study, it's going to help doctors do that for their patients up front, because we all know as parents, we've been in that deer in the headlight. We're at the mercy of our doctors when our kids are first diagnosed. We have to put our full trust in our doctors to lead us in the right direction. And we don't know those questions to ask. We don't know to ask, is there any genetics testing that can be done on my kid's tumor? We don't know that at diagnosis. So I guess my question is, how do we ensure that this is going to be happening, for kids,
Upfront.
for all upfront at all institutions, versus a doctor that's just going to be like, we're just going to pop you on here
Yeah.
on this, standard protocol, something like that, where it's
So-
in a patient's best interest.
That is a brilliant question, and it's at the perfect time. So I'm actually, on on the biology committee of the Children's Oncology Group, the Neuroblastoma Biology Committee. And I don't know if any of you have heard of this, but the Children's Oncology Group and CTEP, the NCI, has a new initiative called the Molecular Characterization Initiative. And it's really a goal to do exactly that. I think what we don't want happening is smaller institutions that don't do their own in-house sequencing, and then you've got the big institutions that's doing it on everybody because it's funded by the state, like New York, right? And so you don't want this imbalance. And so what the Children's Oncology Group and CTEP, the cooperation they have is like, let's reduce that imbalance. And so what they're offering is next generation sequencing for specific tumor types, and it's rolling out slowly. But I'm happy to say that it's going to be rolling out for neuroblastoma at diagnosis for the high-risk patients. And so if there's a patient that has any possibility of being high risk, then they will, if they enroll on the neuroblastoma biology study, they will get the molecular characterization initiative, which is next generation whole exome sequencing, methylation profiling, and that stuff. That will help us understand the MICN. That will also give us ALK. And so while 1531 will be closing soon, the arm that has the ALK will remain open. And so that will still be available for certain patients who get this molecular characterization initiative, so that even when 1531 closes, they want to accrue enough patients to show that it makes a difference in these patients' survival. And those ALK mutated patients discovered by the what we call MCI will have the opportunity to enroll on that study. So I think we're right at the cusp of doing exactly what you desire. Don't put it in the hands of the family, put it in the hands of the institution. All of us, the majority of us, are Children's Oncology Group sites. And I think those big ones that aren't have their in-house sequencing anyway, or if they don't put patients on the biology study, they have in-house sequencing. But most of the smaller institutions are, as well as Children's Healthcare of Atlanta is, CHOP, CHLA, and Sloan Kettering, everywhere. We're all part of COG. And so I think that this will give us an opportunity. What we want to do is encourage families when they will tell you, we have this biology study that if you want to be on a clinical trial, you have to enroll in the biology study. Part of this biology study is next generation sequencing of your tumor if it's metastatic, large, but we don't know if it's metastatic or MICN amplified and that kind of stuff. For the low risk neuroblastoma tumors that are localized and what we call an L1 tumor, they really don't need that next generation sequencing from that standpoint because there's not going to be anything to target, and oftentimes they don't even need therapy at all. And so this was something that we worked with COG to do. We would love to do every neuroblastoma that comes through the door, but there's only so much money through the government, right? And so we're starting to make sure that we can do it on the patients where it matters, the ones that might benefit from an ALK inhibitor, that will give us some information to help us learn how to treat them better. So we're close. And I do believe, and there are other institutions, we do not hold that back from institutions that do their in-house sequencing. It's not going to be like, oh, well, you've got your own, we're not going to give it to you. So it's going to be the same across the board, and it's a very good sequencing platform, so it should catch that.
Thank you so much.
Absolutely. It's
All right.
great. And
Thank-
earlier in the 2014, we just not everybody had it, and we didn't know what to do with it, and we didn't have lorlatinib. And so I think we're getting smarter as we go along, and COG's noticed that. But thank you.
Okay. Thank you, Dr. Goldsmith. Our next speaker is Dr. Shahab Asgharzadeh. Did I say it correctly? Is the director of the Neuroblastoma Basic and